I tell you, it's an exciting time to be practicing otology as things are coming along. I'm going to ask our moderators and panelists to come up. Our next talk is on the sound of silence, a comprehensive discussion of noise-induced hearing loss. Our moderators are Dr. Matt Bush and Quyen Nguyen. And then we have Ann, Hamid, and Isaac, who are going to be giving us some talks. Thank you.
Good morning, everyone, and thank you so much, Bill, for the opportunity to moderate this panel. My name is Quyen Nguyen, and on behalf of my co-moderator and I, we really appreciate the opportunity to bring attention to you for this important topic. You know, just like hypertension for cardiologists and diabetes for internists, noise-induced hearing loss is one of those conditions that creeps in quietly. The sound of silence. There's no pain, no specific onset of symptoms, just a gradual decline that often isn't noticed until it's too late. And so we are all so interested in hearing health and hearing restoration. Just amazing talks from Heinrich this morning and all of the other ANS, AOS talks over the last few days. And so because of that shared interest, I think Bill really recognizes that it's important for all of us to stay current on this topic. Before we begin, I'd like to make a pitch that encourage you to vote for the Academy. Voting ends June 12th. Okay, so we have three fabulous panelists who will talk to us today and update us on noise-induced hearing loss. Dr. Morgan Selleck is going to be talking about the incidence and cause of noise-induced hearing loss, the pathophysiology of this. And then next, we'll have Dr. Hamid Djalilian talking about guidelines for measuring noise, OSHA versus NIOSH, and types of hearing protection and NRR interpretation. And then we're going to have a talk by Dr. Isaac Erbele. And this particular angle from Isaac is going to be very interesting, coming from the military perspective for gun suppressors and treatment of noise-induced hearing loss from a military perspective. So welcome.
Good morning, everyone. I'm Morgan Selleck from the University of North Carolina, and I'm going to be talking to you about just some background about noise-induced hearing loss, prevalence, the etiology, pathophysiology. So I have no disclosures. So I wanted to start with this quote. I thought that this was interesting. This was a physician who said this in 1910. He's also a Nobel Prize winner, so a smart guy. But I think this sort of just speaks to the background about this and the importance of this in the future. He said, "One day man will have to fight noise as fiercely as cholera and pest." And I think we've kind of managed cholera and pest, but unfortunately, despite knowing about the issues with noise, even as far as 100 years ago, I don't know if we've moved the needle a whole lot. And we see that when we look at some of these numbers about the prevalence of noise-induced hearing loss. So it's the second most common cause for hearing loss after presbycusis. It's thought to impact at least 5% of the world's population. And that's probably an underestimate, as it's difficult to kind of ascertain this. 23 million Americans ages 20 and over are thought to suffer from noise-induced hearing loss. It's the #1 preventable cause of hearing loss in the United States. And then just thinking about the population that's at risk for this, 30 million Americans are thought to be exposed occupationally to harmful levels of sound. And then it's 60 million Americans who own firearms, which we know to be, another potential for noise-induced hearing loss. When we think about the different causes for noise-induced hearing loss, we put it into two different categories. One is noise-induced hearing loss in terms of like the cumulative effect of noise, over time leading to hearing loss, versus an acoustic trauma, which is just a single exposure to a very loud noise. When we think about noise-induced hearing loss, it's either recreation or occupational exposures. Recreation being things, like concerts, sporting events, just listening on your AirPods too much to too loud of music. And then, things like firearms could potentially go into both different categories, recreational or occupational. Then when we think about the pathophysiology of this, there's 3 different factors that go into what creates noise-induced hearing loss in individuals. So one, of course, is going to be sound intensity, so the actual decibel level of the sound that you're exposed to, the length of time you're exposed, longer being worse, of course, and then your individual susceptibility to noise-induced hearing loss, which is kind of that factor that's hard to know exactly how much that plays a role, as well as, each person's susceptibility. But all of those together lead to noise-induced hearing loss. And when we think about exposure to loud noises, that can lead to either a temporary threshold shift, and that would be something where we'd expect a rebound in the hearing after 24 to 48 hours, versus a permanent threshold shift, where we don't see that rebound, unfortunately. So what kind of sound intensities are we talking about? Well, in terms of that noise-induced hearing loss, we're really looking at that cumulative effect. That's going to be greater than 70 decibels. That's for that sustained period leading to a cumulative hearing loss over time, versus the acoustic trauma. That's looking at greater than 120 decibels that can lead to an immediate hearing loss. So then what is the underlying pathophysiology of this? What is the mechanism at which this happens? We don't exactly know. It's probably a combination of all the different factors that I'm going to talk about, both mechanical and chemical. But some of the different ones that we currently think about, one being mechanical damage to the hair cells. So noise comes in, and unfortunately hair cells are somewhat fixed. They're attached to the basilar membrane, tectoral membrane, and so that leads to shearing forces with really loud noises, leading to destruction of tip links, premature hair cell death. Then there's also oxidative stress and reduction in blood flow. So again, the noise can lead to production of reactive oxygen species. That can lead to reduction in blood flow, as well as just mechanical reduction in blood flow from noise. Both of those can lead to activation of the apoptotic pathways by hair cells. A third way can be the induction of sterile inflammation. So again, noise can lead to factors like TNF-alpha, interleukins, and chemokines being induced in the cochlea, leading to ototoxicity. And then finally, excitotoxicity due to overstimulation of the hair cells and nerves. So you get, a very large noise that leads to depolarization of more hair cells than what is generally happens in response to sound. That leads to greater release of glutamate, greater motility of your outer hair cells. That leads to reduction in number of your inner hair cell ribbon synapses. And all of that glutamate leads to increased influx of ions into your postsynaptic cochlear nerve, leading to swelling of your cell bodies and then a loss of their spiral ganglion cells over time. And that's it for me. I'll invite my co-panelist, Dr. Hamid, to come up. Thank you.
Thank you. Let's see. Okay, perfect. Thank you. These are my disclosures that are related to tinnitus, unrelated to noise-induced hearing loss. So I'm going to first talk about just general, this is a review for probably everyone, but just in case there are some residents. So basically SPL is how we measure sound in general, so that's just loudness of sound pressure. And HL is what our hearing is capable of detecting based on frequency. So our hearing is best in the mid frequencies. So and SPL HL difference in the mid frequencies is less than 10 approximately. However, in the very low frequencies and high frequencies, our hearing is actually not that good. Even though we can detect sound, there is about anywhere from about 40 to 50 decibel difference between SPL level and HL level. So now, as you know, dB is a logarithmic score. So if every 3 decibel increase is a doubling of the sound pressure. And that will become important a little later, so that's why I'm mentioning that. dBA, when we measure sound, we measure it as either dBA. There are other ones, but most commonly dBA and dBc are used. dBc is what actual sound level is, so how much sound pressure there is. But dBA is corrected approximately for what human hearing is. So if you're measuring sound in a work environment, you're going to measure it as a dBA primarily because that's what's going to be important in terms of how much exposure the individual working there is going to be getting. So there are 2 sets of guidelines for occupational noise exposure. One is set up by the Occupational Safety and Health Administration, or OSHA, and the other one's by NIOSH. NIOSH is part of the CDC, and OSHA is part of the Labor Department. They have a little different sort of terminology. One is PEL and one is REL. But as far as what we're concerned with, you can see what the numbers are, which is 8 hours of exposure under NIOSH is 85 permissible, whereas in OSHA is 90. But when you look at actually every sort of halving of the number is a 5 dB increase on the OSHA scale, but only a 3 dB increase on the NIOSH scale. And NIOSH is actually more realistic because every 3 decibel increase is technically a doubling of the sound, whereas the OSHA, I think, was probably a lot of lobbying from industry that created those numbers. Because you can see how big a difference there is as we get to the shorter time periods. Now, I should mention that this is based on a 40-year noise exposure. So when we look at actually a 40-year lifetime, using the NIOSH numbers at average daily exposure of 90 decibels, about 30% of people will end up with getting noise-induced hearing loss. And as we come down, and at 80 is really when the risk drops. So even at 85, technically there is actually a pretty significant risk of loss of hearing with time. Now, we traditionally have been using the types of hearing protection we use are either earplugs or earmuffs. The earplugs either come in form of like foam or pre-molded or molded, where something like an audiologist would make. There are active noise cancellation, which works primarily for continuous sound. It does not work for intermittent sort of loud sounds. And then there are selective attenuation earplugs. These are earplugs where basically this is one of them. These are the 2 different kinds that are on the market. And some of you may be familiar with the 3M lawsuit that just settled a few months ago, and that was about one of these types of earplugs, actually. And basically they have an opening. They have a small filter where there is, you can see here, where loud sound, when it hits it, it actually diminishes the sound, but normal or less loud sound, when it comes through, it actually makes it through. So, but what you can do if you want continuous blockage, you can close the little opening, and then on the Moldex ones, you just close that thing. But when you have them in, you're protected technically from noise like gunshots, so you can communicate in the military type setting, for example. And of course, there are active and passive type earplugs with electronics, and then earmuffs, there are, again, active and passive devices for that as well. Noise reduction rating on earplugs are primarily calculated in the frequencies that are noted there. There are different methods of doing it because a trained person will do a much better job of placing their earplugs as opposed to an untrained person. And so the NRR is supposed to actually have 2 numbers for what an untrained person will be able to get and what a trained person would be able to get. You won't necessarily see it always, but what is usually done, sort of from a sort of general standpoint, is you correct the NRR by actually reducing it, because generally speaking, the average person uses earplugs incorrectly. And so I actually, for especially patients with tinnitus who are very reactive or have hyperacusis, who are going to be getting MRIs, I tell them, like, you got to use the earplugs this way. So you got to make sure that they know how to use the earplug properly, because then they'll have an episode or trigger after the MRI or something. So if you use double protection, like earmuffs on top of earplugs, that doesn't just that doesn't just take the numbers and add them together. What they sort of approximate is that there's a 5 dB increase to the higher NRR value. So if you have a 30 dB NRR earplugs and a 20 dB earmuffs, you count that as about 35 approximate increase or a decrease in sound. And so really proper use is key. So some people could use earplugs and get a 40 dB reduction, and some people could be using the earplugs and just getting 10 dB, and it would be the exact same earplug. Now, what else do we have beyond earplugs? So a lot of work has been done on enhancement of mitochondrial function, and we've been recently, in the last couple of years, been working on transplantation of mitochondria. So what basic the idea is we take mitochondria from other cells, like muscle cells that have a lot of mitochondria, and then try to get them into hair cells. So we did this in a cell culture model of OC1 cells, which are outer hair cells, and we're able to mitigate oxidative stress-induced cell loss, and we're able to improve their bioenergetics. We recently have actually been able to get mitochondria into live animals, into their hair cells. So you can see it doesn't show up very well, but this is actually the mitochondria, the purple color, and this is sort of the composite imaging. You can see they're actually within the hair cells. And we have now noise-induced hearing loss studies ongoing. And with that, I'm going to hand it to Dr. Erbele to give us the next portion.
I want to thank the moderators and the Otological Society for this honor. Thank you very much. The moderators asked me to talk a little bit of the military context with noise-induced hearing loss. We'll also talk about suppressors and treatment as well. One of the things I want to really make a point about is that although I'm wearing a uniform and talking about a military topic, these are not the military's views. These are my own. So please take everything I say with a grain of salt. One of the things to talk about and think about when we talk about the military context is that we're actually talking about two organizations with competing interests and competing goals. I'm in the Department of Defense. We have the military, and they get exposed to a lot of noise hazards. The Veterans Affairs deals with the sequelae later on in life. The Department of Defense is mainly interested in the ability of their soldiers, airmen, Marines, and their ability to perform a mission. So the ability for that individual not to be disoriented after a temporary threshold shift, that individual to be able to return to the battle after a hearing loss, and whether or not they're able to perform well as an athlete. The Veterans Affairs is a lot more interested in, is a utilitarian organization that's trying to produce the greatest good to the greatest amount of people for the lowest cost. Specifically for the Veterans Affairs, though, hearing-related injuries are routinely in the top 10 number of claims for disabilities. Tinnitus in fiscal year 24 was number 1, hearing loss was number 5. So it's a big, sizable population, and if you're interested in a robust cochlear implant clinic, see Veteran Affairs. So when we talk about the military and that noise exposure, there are a couple key things. Due to a 1980 executive order, OSHA does not necessarily apply to the military itself. However, it's military-specific things. So OSHA can take a look at my operating room and come in and evaluate that. They can't evaluate the soldier who is working on a tank. There are some additional administrative protections. If you're building a building within the military, there's a dedicated safety officer to try to reduce the amount of noise exposure and so forth. Whether or not that gets applied is another story. And then we also have a requirement for annual hearing tests within the military, and that's also an opportunity for audiologists to interact with the individuals to make sure that they're using the hearing aids, the earplugs correctly, and do that training as well. So when I talk about the noise hazards, we've already heard a little bit about this, but it's a continuum of noise. So Dr. Djalilian talked a little bit about steady state noise, but we also have impulse noise that comes from gunfire. We also have blast overpressure, which is essentially an extension of the continuum. And we see steady state noise just with being on a ship or being in a tank. We see impulse noise with gunfire, and we see blast overpressure with firing mortars and so forth. But this is a continuum of noise hazards that people experience. When we take a look at this information, we have a couple different levels to keep in mind. Impulse noise, according to OSHA, needs to be limited at 140 decibels. Blast overpressure, 4 psi is typically the threshold, and that's the threshold at which 1% of people end up getting a tympanic membrane perforation. When we talk about the pathology specific that's at the extremes, So we have outer hair cell loss. We also have spinal ganglion loss. We also lose synapses as well. We think that repeat exposure, and this is something that we showed downstairs in our posters, but repeat exposure can be specifically deleterious and a specific hazard. We also think that this loss can cause auditory processing issues that make it difficult for people, even with one temporary threshold shift, to eventually have synaptopathy and some hidden hearing loss as well. There are some challenges with noise at extremes, specifically measuring the loss. And there are also limits of protection to the ear, too. When you start getting to the 140 decibels, when you get to the 160 decibels and so forth, you start having conductive exposure through your body to your ear. And so it doesn't matter at some point how much you're protecting your ear, you're still going to get hazardous noise exposure when you start getting to extremes. Also, when you get to extremes, there are injury to other structures, especially air-filled structures like gut and lungs. And we also think that some of that blast energy affects the brain as well. So mitigation specifically within the military, active noise canceling is nice because at a certain threshold, it'll actually actively cancel the sound. So you can be in an environment where you're firing rounds, and you can hear while you're not shooting, but it ends up having noise canceling when you are. Suppressors, which I'll talk a little bit more, and then low velocity rounds. So one of the things I want you to look at this picture, you see pressure lines coming out from that blast. So that's one noise exposure. You also see that bullet that's going out past that blast, and you see the supersonic lines that are coming from it. So with most rounds, you have actually two sources of noise with each round that you fire. Low velocity rounds can at least eliminate the supersonic blast that comes from a round. The suppressor is what can suppress at least some of the noise that comes from the blast around the muzzle. So suppressors are great. They do reduce sound. Usually, and they can reduce sound on the order of about 2 decibels up to 28 decibels, especially in combination with low velocity rounds. Specifically, when I talk to the operators, they care about the noise as far as the disorientation, but they also care a lot more about the barrel flash. The fact that it reduces the barrel flash means that you can hide where that information is coming from the enemy. And that's actually more important to them than the actual reduction in sound. It does affect the round itself, but the point is just that alone these devices are insufficient, and you have to wear hearing protection in addition to these sound lowering devices. And I'll talk briefly about what happens when you do, because we're talking about people who are young and may not wear their hearing protection when they go out to the range. Based on the information that we have, the best way to approach this is to approach an acute noise-induced hearing loss, just like we treat sudden sensory hearing loss. Specifically, steroids and hyperbarics do seem to help. We have work showing this. I'm also currently working on some preclinical work looking at anti-inflammatories and neural regeneration strategies to help a little bit with restoring hearing. And hopefully we'll be able to share that next time. So thank you very much.
Good morning. Thanks for sticking with us, and thanks to our panelists for excellent presentations. We have a few questions that we want to pose to our panelists. You know, we're always challenged when we're dealing with folks in different industries. In Kentucky, we've got coal miners who battle to wear hearing protection because they don't feel safe if they can't hear the equipment, can't hear their coworkers, and so they need to be able to communicate. And I think, Isaac, you kind of touched on that a little bit as far as the military perspectives. But from our other panelists, too, and Isaac, feel free to chime in, how do we counsel some of these patients that are struggling in the workforce, certain occupations, to safely communicate, but then also to protect their hearing in the long term?
So there are depending on sort of the type of earplug, so there are the selective type earplugs that you can sort of close and open, so you could get more continuous. But actually, even using earplugs somewhat loosely in the ear canal will give you approximately a 10 dB drop. So depending on the environmental noise that's there, so that they're able to communicate for the purpose of communication. And no earplug is going to stop people from hearing other people talking. Because if people are talking about a 60 dB level and people have normal hearing, they're still going to be able to hear them. It's going to be, of course, muffled. But what I tell patients sometimes, depending on the environment they're in, is that they can at least put the earplug in loosely, and then if they anticipate there's going to be louder sound, is to push it in. There are, of course, the electronic ones that Isaac mentioned as well.
I also played a plug-in for the high-fidelity earplugs that seem to be, anecdotal at least, people seem to have better hearing with high frequencies, and that seems to be helpful, especially, I know we're trying to talk about musicians and things like that. That's something that the musician community really appreciates.
Yeah.
Yeah, I think this is just difficult, especially because it's a perception, especially for musicians or DJs that I've had in clinic who just feel like they just don't hear as well. And I think it's interesting because there are some studies where they've had musicians wear earplugs and then they make them make music with the earplugs and without, and there's no difference, from the listener's standpoint. But from the musician's standpoint, they really just feel like it's different. So I think it's a little bit of a perception shift that they need to have in terms of, how important their hearing really is.
Any specific advice for those musicians that want to be able to fully, embrace their art and their music, but then also protect themselves? Any particular brands? Any certain hearing protection that you work with, either within the clinic or outside of an industry?
I usually recommend the so-called musicians earplugs, which they come in actually non-electronics and electronic variety, so you can get them through an audiologist or you can get them outside, so that has certain levels of 10 or 15 dB, et cetera, drop. They have to use them properly for it to work, of course. I do advise them to not have a big speaker towards them when they're performing, and to, if they're practicing, to keep the volume as low as it can be done, because when they're practicing, they don't need to listen to it at the same level as they're going to be performing, of course. So it's just kind of just basic things like that. I do advise, and I don't know if that'll come up later, but for them to take on an ongoing basis a supplement that has vitamin A, C, and E, and magnesium, just because those have been shown to help with treatment side. So it's beneficial for them to use it on an ongoing basis.
Great segue. Go ahead.
I just want to make a plug that encourage your audiologists and your staff to offer your services to the musicians in your community. I'm engaged with the San Diego Symphony, just talking to them, and it's a great way to establish a partnership about this.
Yeah, great point. Let's transition to treatment. In the acute situation, temporary threshold shift or potentially a permanent threshold shift, somebody that, was negligent, maybe forgot to put in their earplugs at the firing range, who's doing this on a weekend. What are your protocols? How are you counseling patients? How late would you be willing to treat someone who's had a damaging noise exposure?
I think we sort of mentioned this, but I treat it, like I said, in sensorineural hearing loss, so steroids. I think there's some good evidence for hyperbaric oxygen, but that's very difficult in my area to kind of get patients actually into in a timely fashion and to get insurance to pay for it. So typically, I'm just treating with steroids.
I'll also add that one of the papers that we're trying to get through seems to suggest that the timing doesn't matter quite so much. So if we were looking at 14 days versus after 14 days, and that there didn't seem to be a difference in the improvement either way. So I would say that even if it's a little bit late, I would still treat.
Yeah. What just for practical purposes, just tell me, intratympanic injection, oral steroid, both. Tell me the doses. I'm just curious to know what's the range of differences in opinions.
So if it's both ears, I typically just do oral, and I'll do 60 milligrams for 10 days, and then a rapid taper down by 10 milligrams every day. And then I'll typically treat out to like 6 to 8 weeks, even though I'll tell people I feel like I don't know how well it'll work if we're at the end of that time frame.
I usually use 1 milligram per kilogram up to 80 for 7 days, and then taper every 2 days by 20 approximately. And then I do intratympanic only in the first 3 days, because most of the temporary threshold shift will reverse by after that, and at that point you really don't know if you're actually what you're treating, because sometimes it's just all there is tinnitus. And of course, as you know, you can lose 30% of the hair cells in a certain region in the cochlea and have no changes on the audiogram. So an audiogram doesn't necessarily tell you there has been damage or not. And then I do give them the sort of the cocktail of the 3 vitamins, the antioxidants. There is evidence on N-acetylcysteine, and from Michael Hoffer's work, he said that the over-the-counter supplement's not very good, so we usually give them the pharmacy grade one, which is like a liquid, which apparently doesn't taste very good. But there's a loading dose, and then there's like a BID dosing of that after that, usually 2 grams BID. And then vitamin B12 has some evidence as well.
I do 60 for 2 weeks, and I'll inject if I need to, if it doesn't work.
I want to ask you one last question. What's needed in our field specifically as it relates to noise-induced hearing loss? Do we need practice guidelines? What are our research gaps? What kind of consensus statements, policy change, perhaps educational campaigns? What are your thoughts about what's really a priority for us to focus on?
I think all of those, but in terms of priority, we are, through the hearing committee, we've put together a position statement that I just actually sent last night to the academy to potentially adopt for recreational noise, because there are guidelines for occupational noise, but there are no guidelines for recreational noise. And having gone to concerts with my kids recently for the first time in my life, they're ridiculously loud. They're like over 120 decibels, and even very well used earplugs will still probably not adequate. So I think that's something that's definitely needed, not only just to protect the people who are there, but also the people who are working there and the musicians themselves.
I had you pegged as a Swiftie, Hamid.
Yeah, no, just Sabrina Carpenter.
Anybody else other thoughts about things we really need?
I think it really needs to be a public health. I think there's not enough information from the patient standpoint. I think it's like smoking or any of these other big public health issues. I think people just don't pay attention to it, and we really need to put this focus on people being aware of it, even at a baseline, because I just don't think there's that awareness.
Yeah, right on.
I think that focusing right now on practice guidelines and consensus statements makes the most sense. I think in the current environment, policy changes are going to be outside our ability.
I think we've got maybe time for a couple questions here as we're abutting the break here. So go ahead, Nancy.
Great panel. Question, I'm wondering if any of the panelists or our moderators could comment on the safety of what's becoming very popular, which is bone conduction devices to listen to music, to speak on your phone. And there's actually a European company that's promoting it for young children with otitis media, sort of as an alternative to more traditional treatments.
Thoughts? Aftershocks, I think, is the headphones.
That's definitely a popular one in the
Yeah.
U.S.
So, bone conduction through the skin, as you know, drops off after 4,000 hertz, so that you don't get much beyond 4,000 hertz. Generally, sound quality is not actually as good as air conduction is, of course, but people can actually hear outside sound. That's sort of the benefit. But that being said, is of course, the higher the frequency, the more strength there is to the sound pressure, the power there is, I should say, to the sound. So. It's less damaging, of course, and generally most commercial headphones sort of top out at a certain level so that you really can't crank them to a level that's going to damage hearing.
Thank you.
Great panel. Couple quick questions, points. So you mentioned N-acetylcysteine and the work of Hoffer and Kopke, and as you probably know, we did a lot of work looking at lipid peroxidation inhibitors and acetyl L-carnitine, which is different than carnitine that bodybuilders use, better absorbed into the brain, to the inner ear. Alpha-lipoic acid coenzyme Q10 and glutathione. Glutathione's not well absorbed, neither is N-acetylcysteine. So the glutathione and ethyl ester is better absorbed and gets into the ear. So we actually showed a statistically significant protection of noise and age-related hearing loss using these things, and have a couple of patents on it. But I was blessed to present to a bunch of three-star generals at the Naval Academy base a number of years ago, and recently at the Department of Defense. And you know, I started out that the best way to protect against our men and women from these types of exposures is not to send them into areas of conflict. The room, of course, got deathly silent, as you would imagine, and I said, of course, we have ways that we have to protect, and went on and talked about a lot of the signs that you have done, so thank you to all of that. What we're not really addressing, and I didn't really hear, is that we know that noise causes things like hypertension. It raises insulin, actually lowers insulin, but raises glucose and causes a lot of significant systemic stress. So I was kind of curious about what you think about the hypertensive, the diabetes, and there's a lot of studies to show the systemic effects of noise, people living near airports and things of that nature as well.
I mean, I don't know if I can address it directly, but at least, I think there's definitely systemic effects from noise. There's no question about it, because actually, just when we look at actually the ear, all of the changes aren't actually occurring in the cochlea. They're occurring centrally as well, and then there's actually vascular changes that occur as a result of a loud noise exposure. But at the same time, I don't know if, unless someone's getting exposed to noise a lot, 24/7 or 16 hours a day, I don't know how that could potentially cause hypertension on its own. There are probably, many other risk factors, obviously, including genetics and whatnot, that go into that.
I
Mike?
actually think that, noise is a type of torture, right? I mean, you put somebody in a sound booth and then you blast them with sound, that causes a lot of hypertension and stress. So I think that's something very interesting to look at. Thank you.
Mike?
More of a comment. Hamid, thank you for the shout out. I just wanted to say that I appreciate the panel's work, and I appreciate Dr. Slattery, the AOS, for shining a light on this vital topic. We don't talk about it enough. We talk about it at ARO, but not at this meeting. So thank you very much for shining a light and having these great panelists, and Quyen and Matt.
Thanks. Jim?
A similar congratulations. A great, very, very important topic. This is more of a comment than a question. I just want to put a shout out for the work of the World Health Organization is doing in this field. You talk about public health campaigns. I've got a very active campaign called the Make Listening Safe campaign, and also very involved with sort of guidelines for public spaces, for cell phones, for gaming. The most recent contribution is providing some guidance for companies that are making gaming platforms and the noise exposure with that. So a really important topic, and an example of how the WHO directly serves our specialty. I just want to put that plug in. Thank you very much.
Thank you. Last question or comment?
Thank you to the panel. Roya Zadarmaki, Washington, D.C. area. Do we have any information on our risk of exposure when we drill all day in the operating room?
Yes, there is data on that. There are quite a few people who have published, and the drills can get up to about 83 to 85 decibels. So it is a hazardous noise exposure that we're exposed to, especially if we're drilling for longer periods of time. It's one of these situations, just like when, with the active duty, where it's a matter of making sure that you have situational awareness, but also protect yourself. I care about my hearing. I don't wear hearing plugs while I drill. I don't know if my colleagues do or not, but there is evidence on that.
Thank you.
Yeah, I try to go to the farthest corner of the operating room as I can when the resident's drilling, so that can protect my hearing, and I sometimes will turn my back just to reduce the volume.
Maybe for more than one reason.
Hamid, your discussion about the noise with concert and recreational noise. I went to a concert once, and I had my little decibel meter on my phone. I was monitoring the dB, and it was under 85 decibels. And of course, I was the nerd with the musician earplugs in for the whole concert and halftime. And so I thought, I'll just take one of my earplugs out. I took the one earplug out, listened to the rest of the concert. Everything was under 85 dB for the rest of the concert. And then I walked out of the concert venue and pulled the earplug out, and I realized I had tinnitus in the ear that was unopened.
Oh.
And so, you know, it's one of those mild things. Of course, had I not been in the hearing world, had I not taken one out, had I not looked at the dB, but so my point is, it is interesting that we probably are hurting ourselves a lot more. Maybe the standards aren't as strict as they need to be. So maybe it's just me, my metabolic state is not as good as it should be, but just kind of an interesting N of one, so just something to think about. So I want to thank the panel. They did a great job for the noise, silence of sound, and so thank you very much. We're going to